Hello everyone. So today's topic of discussion is emergency contraception. So this is very important and it is very useful for us to know what are the exact methods of emergency contraception. And it is not only IPIL which is available in the market, but we have to exactly know what are the methods available, what is its efficacy and what should be given and when it has to be given at the right time. So why delay? Let's move on to today's agenda. So I would like to cover in these headings. Firstly, introduction to emergency contraception. When is it indicated? What are the methods available? How does it work actually? Like what is the mechanism of action? Its efficacy and effectiveness and any drug interactions if present. And what are the contraindications of emergency contraception and specific considerations like in breastfeeding, and how do we go about, like what is the exact algorithm we have to follow while prescribing an emergency contraception. So, emergency contraception is a means of reducing the risk of conception of an unintended pregnancy following unprotected sexual intercourse. So, it is called UPSI, that is UPSI. So, whenever there is an unprotected sexual intercourse, what method can be used or what drug to prescribe to reduce the risk of pregnancy in simpler terms is called as emergency contraception. Mainly, the indications of emergency contraception are these three. That is, when the woman is not using hormonal contraception. So, in her natural menstrual cycle, if there is any unprotected sexual intercourse and she does not intend to get pregnant, that time we have to offer her this emergency contraception. And immediately after pregnancy. So, at least 21 days, first 21 days of the delivery, it is not needed. But after 21 days, it is definitely needed if there is any episode of oopsie. So, why 21 days is the limit means that is, it is the least amount of time where an ovulation can occur after delivery. But what about after abortion or after a molar pregnancy or after ectopic pregnancy or after evacuation of gestational trophoblastic disease? So, if there is any of these things, then only 5 days is the period where the EC is not indicated. So, if the period crosses 5 days and there is any episode of unprotected sexual intercourse, then definitely we have to offer a emergency contraception. So, after pregnancy, 21 days. After molar abortion or ectopic, it is 5 days. But even after 21 days, if the criteria of lactational amenorrhea is met, still emergency contraception is not indicated. So, what are these criteria? One, the mother should be completely breastfeeding the baby, that is exclusive breastfeeding, and the interval of breastfeeds in the day should not exceed 4 and in the night should not exceed 6. That is first criteria of lactational amenorrhea. The second thing is the mother has to be amenorrheic and it should be less than 6 months of her childbirth. So if these three criteria have met, then she need not take an emergency contraception. If not, definitely, if an unprotected sexual intercourse has occurred after 21 days of delivery or after 5 days of abortion, it is definitely indicated. And the next important indication is missed regular contraception. So if she misses a hormonal pill, or if the pill free interval is more, or if the patch free interval is more of, or if there is a vaginal ring and the ring is not placed properly afterwards. So all these are missed of the regular contraception. Even in such cases, we have to provide her emergency contraception. So, we have understood what are the important indications for emergency contraception and the need for emergency contraception. Now, we have to understand what are the methods available and what is the main mechanism of action of each method to prevent pregnancy. So, these are the three important emergency contraceptions which are available. One is copper T, that is the intrauterine contraceptive device. The second one is ulipristal acetate. It's a selective progesterone receptor modulator, and a levonorgestrel, which is a progesterone derivative. So, firstly, we'll discuss about each method. First one and the most efficacious method is the copper T, that is IUCD. So this copper T, what is the mechanism of action of causing emergency contraception? It has the gametotoxic effect. So this copper does not allow the gametes to get fertilized. So what will happen? The sperm motility is decreased, the oocyte motility is decreased, and it prevents fertilization. So if fertilization also occurs, it prevents implantation by altering the endometrium receptivity. So it causes a foreign body reaction in the endometrium. So this repels the zygote if already fertilized. So copper T has two mechanisms. One, it prevents fertilization, and the second one is it prevents implantation also. So this is the main mechanism of causing an emergency contraception. The second one is ulipristal acetate. So as I already mentioned, it is a selective progesterone receptor modulator, and mainly it prevents ovulation. So it delays the ovulation, so at least for 5 days. So even if the sperms are deposited in the genitalia, they will be non-viable by the end of 5 days. So that is how the fertilization will not occur, because there is delayed ovulation. So this is the main mechanism of ulipristal acetate. That is why it can be given up to 120 hours after an unprotected sexual intercourse. The third important drug is the levonorgestrel drug. So this also delays the ovulation. But this delay in ovulation can occur only up to 72 hours. So if the unprotected sexual intercourse is within 72 hours, then levonorgestrel is highly effective. But if it is crossed 96 hours, the efficacy of levonorgestrel decreases. So why is that like that? Because ulipristal acetate prevents or delays ovulation even after the LH surge has started to occur. But it does not prevent once the LH peak has occurred. Surge is occurred, it will prevent or delay ovulation by the bringing back of LH surge. But levonorgestrel cannot act once the LH surge has occurred. So it will not delay ovulation, or it will not prevent ovulation once the LH surge has started. So that means definitely ulipristal acetate is more efficacious than levonorgestrel. So there are two types of contraception, emergency contraception, as we can see. One, it's an intrauterine contraceptive device, and the second one is oral tablets. So in oral tablets, ulipristal acetate and levonorgestrel are available. The highest efficacy is for the copper T, and next comes the ulipristal acetate, and next is the levonorgestrel. So these are the methods available and the main mechanism to prevent pregnancy. So, as I already mentioned, the pregnancy rate in copper T is less than 1%, followed by ulipristal acetate, that is 1 to 2%, and lastly the levonorgestrel, that is 0.6 to 2.6%. Now we have certain scenarios. So what is the effect of weight and BMI? So irrespective of the weight or BMI, copper T can be inserted as a method of contraception within 120 hours of unprotected sexual intercourse. But the oral emergency contraceptive methods have some weight and BMI limitations. So if the body weight is more than 70 kg, or if the BMI is more than 26 kg per meter square, then levonorgestrel is not effective. So in these cases, we can give ulipristal acetate. And the next important situation is if the BMI is more than 30 kg per meter square, and if the weight of the individual is more than 85, even ulipristal acetate will not be effective. In such situations, we can give the double dose of levonorgestrel, that is 3 milligram. So the normal dosages of ulipristal acetate and levonorgestrel are: ulipristal acetate is available in 30 mg tablets, and levonorgestrel is available in a tablet of 1.5 mg. So I will repeat once again. If the weight is more than 70 kg and BMI is more than 26 kg per meter square, give ulipristal 30 mg because levonorgestrel will not be effective. If the weight of the individual is more than 85 kg and BMI is more than 30 kilograms per meter square, then give double dose of levonorgestrel, that is 3 mg, and ulipristal will not be effective. So next, very important, that is the drug interactions. So what if if the mother if the woman is already on some drugs, what method of emergency contraception is prescribed or which is more effective? So firstly, we have to understand irrespective of the drugs, we can give copper T, that we can put up copper T irrespective of whatever drugs she is taking. But if copper T is contraindicated, so what are the situations in which a copper T is contraindicated? Firstly, if there is any active genital infection, if the woman is chlamydia screen positive, or if she has any previous history of ectopic pregnancy, or if she has any or if she is nulliparous or unmarried, and if she does not want to put a copper T. So these are some of the relative contraindications for a copper T. So in these cases, we have to go for an oral contraception, that is oral emergency contraception. So what are those options available? One is the ulipristal acetate and second one is the levonorgestrel. So in these, if the woman is on these three types of drugs, we have some limitations. So, if the woman is taking enzyme inducing drugs like, so I will tell you the mnemonic, it is called as 3Ps, 3 pins and topiramate. So these are the anti-epileptic drugs which are enzyme inducing, and these will metabolize ulipristal acetate and decrease its efficacy. So when the woman is on enzyme inducing drugs like primidone, phenobarbital, phenytoin, carbamazepine, escarbamazepine, oxcarbamazepine, and topiramate, in these women, we have to not give ulipristal acetate. Levonorgestrel is preferred. So I will repeat, if the woman is on enzyme inducing drugs, the ulipristal acetate should not be given and levonorgestrel is preferred in cases of oral contraception. And the same, if the woman is on some drugs which increase the gastric pH like osmeprazole, even in such cases, ulipristal acetate will not be effective and we have to go for levonorgestrel. And last one, if the woman is on any progesterones, that is if she is on any hormonal contraception which is ongoing and she is missed, then also ulipristal acetate is not to be given. So if she is on progesterones at least 5 days before the unprotected sexual intercourse or 7 days after unprotected sexual intercourse, if she is taking, then we cannot give ulipristal acetate because it decreases its efficacy. So in all these three cases, if the copper T is contraindicated, then we have to go for levonorgestrel 1.5 milligram. Otherwise, if copper T cannot be contraindicated or if it can be given, the best choice is copper T. But if it cannot be given and we have to go for an oral drug, then we have to go for levonorgestrel instead of ulipristal acetate. So what are the contraindications and restrictions? So already I told you that copper T cannot be given in active genital tract infection, chlamydia screen positive, previous history of ectopic, or in relative contraindications like nulliparous, unmarried after sexual intercourse or something like that. But what are some of the restrictions which are available? So as already I told, if there are any drug interactions, ulipristal acetate cannot be given, and in such cases, levonorgestrel can be given. As such, there are no contraindications or restrictions for levonorgestrel. Even if there is hepatic impairment, ulipristal acetate should not be given. Next, what about breastfeeding? So obviously in the postpartum period, the mother will be breastfeeding, and in this period, if there is any unprotected sexual intercourse, which contraception to be given? So usually copper T is relatively contraindicated between 48 hours after birth till 28 days after birth, that is 4 weeks. So in this period, we cannot insert a copper T. So in this period, we have to go for oral contraception. So the next best drug is ulipristal acetate. But if the mother is taking ulipristal, she has to not breastfeed the baby for 7 days. So it is not indicated to breastfeed the baby for 7 days. So these 7 days, she has to express the baby, express the milk and discard it, and she has to use some formula feed. So if the mother has taken ulipristal acetate, she has to deny breastfeeding for 7 days. But in these situations, levonorgestrel can be safely given, and there are no proven contraindications of levonorgestrel during the time of breastfeeding. So next, what method to use? So based on efficacy, already I told first of choice is copper T, second choice is UPA, that is ulipristal acetate, and the third choice is levonorgestrel. But if the mother has some other scenarios, which is the best method to use? So when not on any hormonal contraception, then whatever order I told, it is the best. If the mother has missed some pills, especially progestogens, if she's missed mini pill or progesterone only pills, then ulipristal acetate cannot be given for first 5 days of that missed period. So if it is elapsed after 5 days, then we can give ulipristal acetate. But in the presence of progesterone, we cannot give ulipristal because it decreases the efficacy. So in cases of missed pills, the best is copper T. But if copper T cannot be given, we have to give levonorgestrel and not ulipristal acetate. Next, in adolescents, we can give all types of contraception irrespective of anything. So even in adolescents, copper T can be inserted safely. We can give UPA and levonorgestrel as well. Even this applies the same to perimenopausal women also. All three can be safely given unless there is any hepatic impairment where UPA is contraindicated. And after sexual assault, there used to be a previous consensus that sexual assault we have to not insert an IUCD because it might lead to intrauterine infection, but this is not proven now. So present consensus tells that even after sexual assault, any type of method of contraception can be safely used. So after speaking so much about emergency contraception, we have to understand what are the side effects. So some of the most important or common side effects after a morning after pill, it's also called as postcoital contraception or morning after pill. So it might change, some of the changes can occur in the normal menstrual cycle. It can be either delayed or heavy, or it can be early. So some changes can occur. There might be slight or vaginal bleeding. Breast tenderness might be there. Some amount of nausea, vomiting. Sometimes headache and dizziness, especially with ulipristal acetate. In small amount of abdominal pain and cramping. These are all some side effects, and there are no actual adverse events as such. Coming to if there was any previous history of unprotected sexual intercourse in the same cycle. So, what if there was an unprotected sexual intercourse and she has used some emergency contraception, and now there is a second episode of oopsie? So, what do we do that time? So, if the woman has taken levonorgestrel previously, she can again take levonorgestrel. If she has already taken UPA, she can again take UPA. It is okay, and it is okay to take the same medication again, and there are no actual contraindications. But if she has taken UPA, that is ulipristal acetate, and presently if ulipristal acetate is contraindicated, levonorgestrel cannot be given for at least 5 days. There should be a gap of at least 5 days of giving UPA and levonorgestrel. And it is different in the next scenario. If levonorgestrel has been taken and now if she has to take UPA, there has to be at least minimum gap of 7 days, because the effectiveness of these drugs decreases if taken within this interval. So I will repeat, if UPSI has occurred in the same cycle, if she's already on copper T, that will be protective and it acts as an ongoing contraception. If she has taken UPA, she can again take UPA. But if she's taken UPA and presently UPA is not indicated, levonorgestrel should be taken after 5 days of her previous ulipristal acetate. If earlier levonorgestrel has been taken and now levonorgestrel is contraindicated or not indicated, ulipristal acetate should be taken after 7 days. This interval is important as if it reduces, the effectiveness of the contraception decreases. And the second one is, if ulipristal acetate is given, we cannot immediately start any hormonal contraception. At least 5 days gap should be there to start an ongoing hormonal contraception, because this decreases the efficacy of ulipristal acetate as a emergency contraception. But if we give levonorgestrel, immediately we can resume hormonal contraception, because this does not have any effect over the efficacy of levonorgestrel. So if copper T is used, we can continue copper T as an ongoing contraception. If UPA is used, give 5 days gap and then start hormonal contraception and ask them to be sexually abstinent for those 5 days. And third, if levonorgestrel is used, then she can immediately resume her hormonal contraception. So what about future contraception? The same thing. So if UPA is taken on Sunday, we have to start hormonal contraception after 5 days. And this after ulipristal acetate, we have to use an oral contraceptive pill after 7 days, vaginal or transdermal patch after 7 days, pill after 2 days, and progesterone only implant after 7 days. This is important because if the interval is reduced, then the efficacy of ulipristal acetate decreases. So these are the very important decision making algorithms for emergency contraception. So we have to be very much aware of what case scenario she comes with, because everyone will not have the same presentation. So based on that and based on the duration of the UPSI which has occurred, that is unprotected sexual intercourse, our decision making will change. So I will brief you out about the algorithm available. So if the currently it is less than 120 hours, that is 5 days since the last episode of unprotected sexual intercourse. If it is yes, an additional contraceptive method is used, then we can currently, if it is less than 5 days from the day of ovulation, we can definitely give copper T. And if we don't know whether it is nearing if it is nearing ovulation, then we have to consider pregnancy test if UPSI is occurring more than 21 days ago. Or we have to offer oral emergency contraception and a suitable ongoing contraception. And one more thing I have to emphasize is, after ovulation, oral emergency contraception is not effective. So if the ovulation is occurred, the only method is copper T. That is, if the ovulation has occurred and it is less than 5 days of anticipated ovulation, then only copper T is the method of emergency contraception, because these oral contraceptive methods prevent or delay ovulation. But if it is already occurred, there is no point in taking an oral emergency contraception. So the golden rule is, ovulation has happened, only choice is copper T. If ovulation has not occurred, then we can choose either copper T or oral emergency contraception. So next is, if the C is less than 120 hours. No. If it is less than 5 days after the earlier date of ovulation. If it is yes, then you can offer copper T. If it is no, then both are not effective. We have to start any suitable quick start of contraception. Next, if it is at least currently less than 5 days after the earliest date of ovulation, you can offer copper T. If no, then we can offer oral emergency contraception and a suitable ongoing contraception. But we do not know whether it will work. When coming to oral contraception, so if COP-T, it is the most effective, as I already told. But if the criteria to insert copper-T is not met, or if it is not acceptable by the woman, that time we have to consider oral methods. So if the last oopsie has occurred less than 96 hours, yes, then we have to see if it is less than 5 days prior to the estimated day of ovulation. Yes, then know that the oral emergency contraception is unlikely to be effective even if taken after ovulation. So the best choice in this is UPA, that is ulipristal acetate. So we have to start contraception after 5 days. If we have to consider copper T, we can consider within 120 hours. So next is if the body weight is more than 70 kg and the BMI is more than 26 kg per meter square, then we cannot use LNG. So UPA has to be used. If the body weight is more than 85 kg and BMI is more than 30 kg per meter square, we cannot use UPA also. That time give double dose of LNG, emergency contraception. If the last oopsie is less than 120 hours, then the only option we have is copper T. If we do not want to give copper T, then we have to give UPA because LNG IUS is not effective after 96 hours. So in simple terms, I will tell you, you remember, first method of choice is copper T. If copper T is contraindicated, then we have to choose between UPA and LNG. If the mother or if the woman is on any hormone pills, or if she's on any progestogens, or if she's on any enzyme inducing drugs, or if she's on gastric pH lowering drugs, then we have to go for LNG. Otherwise, we have to go for UPA. If the body weight is more than 26 and weight is more than 70, take UPA. If the body weight is more than 85 and BMI is more than 30, then give double dose levonorgestrel. So this is simplified version of emergency contraception. First is copper T, next is UPA, next is levonorgestrel in the same order. If it is 120 hours, it is copper T and UPA. If it is 72 hours, it is LNG. 72 to 96 hours, LNG might work, but it is not very sure. But after 96 hours, there is least efficiency of LNGs because it cannot occur after the LH surge. So this is how 5 days of UPSI, copper T or UPA can be given, but only 3 days we can give levonorgestrel. So these are my references, and I want to highlight to a point that my take-home message for today is we have to explain all methods of emergency contraception to the woman, and we have to ask her the cycles are regular or not. So if her cycles are regular, we can predict the day of ovulation. So how do we predict the day of ovulation? We will take LMP and we will add the number of days of her shortest menstrual cycle, then we will minus 14. So this is how we can predict the date of ovulation. So if the ovulation has already occurred, the only method of choice is copper T. If ovulation has not occurred, then we have three choices. One is copper T, ulipristal and levonorgestrel. If it is elapsed more than 120 hours, then neither of these are effective. But till 120 hours, copper T and UPA are effective. But till 72 hours, levonorgestrel is effective. In cases of copper T contraindications, we can give oral oral drugs like UPA and LNG. Only if UPA is contraindicated, then LNG is given. So the most preferred is copper T and the least preferred is LNG. But the irony is we gynecologists are using only LNG, that is I pill, which is routinely available even over the counter, but this is not recommended. So we have to take a brief history, any previous history of UPSI, any previous emergency contraception, any ongoing hormonal contraception, whether she is intended to continue contraception or whether she is desirous of future contraception. So all these things we have to keep in mind and then prescribe her an emergency contraception based on its efficacy. But all methods have to be discussed and we have to ask the woman to choose. So this is the cafeteria approach where we give all the methods and she has the right to choose. So I hope this session on emergency contraception was useful and I will come up with some more and much more useful topics which are very helpful to deal with our day-to-day cases. So till then, see you. Happy learning.